Welcome to this pre-recording. It's a great pleasure for us to present on behalf of the PPA. A little about who we are. I'm Clair Jacobs and my role is Physiotherapy Lead at Input, Guy's and St Thomas's Pain Management Unit. I'm presenting with Leila Heelas, the Clinical Lead Optimise Pain, Oxford University Hospital. Leila will introduce herself shortly. Leila and I prepared this presentation for a conference which has unfortunately been cancelled due to COVID-19. We have therefore decided to convert the presentation for the PPA to use as an open access webinar. Please do bear in mind that we are in different locations geographically as we present. We have also, due to ease of recording, changed the order of the slides. In normal days, we run primarily group-based pain management programs based on an acceptance and commitment psychological model. We have both been working with complex pain patients for many years and are very pleased to be able to share some thoughts and ideas with you. Learning objectives of this webinar are to gain an appreciation of the role of psychological and social factors in chronic pain management, to understand some of the psychologically informed physiotherapy approaches used in pain management, to consider and reflect on our conversations and interactions, to observe and experience a small number of pain management methods to use in everyday clinical practice. A little bit about the PPA, the Physiotherapy Pain Association. We are a growing organisation and last year celebrated 25 years. Dr. Paul Cameron led a key session for our members where we recognised key areas for our strategy. These include supporting people in pain, supporting training, education and supervision, and raising the profile of the PPA. A little bit of a disclaimer now regarding this talk. We are aware that we work somewhat in a bubble in tertiary care, although things have changed quite rapidly in the last few weeks. We have all had to quickly learn and adapt to virtual treatments and ways to support people in pain through the crisis. We work in multidisciplinary teams and have the benefit of supervision and support from colleagues. We are aware that the majority of you, work alone and that you are often managing complex clients and interactions on a daily basis. This talk does not focus on specific pain conditions, and it's also not a recipe for how to manage patients. Many of us have pain management skills intuitively. Within our everyday interactions, interviews, and conversations with patients, we are constantly moving between models and ideas to collaborate best with our patients. To know when to delve deeper, to decide when and how to step back, and to formulate what is going on in order to decide our direction of treatment. There is much that we can talk about, and it is a subject that we are very passionate about. We want this talk to be as much a reflection on your own conversations and interactions that you have daily with your clients, interspersed with theory and evidence to provide food for thought. We will use a case study to highlight our thoughts and ideas, and also introduce you to a small number of skills that we hope that you can explore in your everyday practice. For the purpose of flow of this presentation, we won't be referencing every source. However, we will provide links and references to those whose work we have drawn on in creating this resource at the end. Let's set the scene. A few facts about pain. Chronic pain, defined as pain that lasts for 3 months or more. Musculoskeletal pain is one of the most common complaints in adults, experienced by 30%. 1 in 8 people live with persistent pain conditions. Pain impacts on physical and mental health, daily activities, and is a frequent reason for healthcare consultation. Much is known about the overuse of medications in managing pain. People can take between 1 to 4 pain medications, often with quite erratic use and quite significant side effects. We know that pain can persist for no apparent cause, and often treatments may fail. People experiencing pain often present with co-morbidities, for example depression, anxiety, fatigue, lack of energy, sleep disturbances, to name a few. Some may be a result of the pain, or there may have been predisposing conditions. Chronic pain matters most when it leads to behavioural disturbance, when pain gets in the way of doing the things that matter to us. Most of us live with some level of pain and can manage this, but it can start to affect our sleep, our activity, and our relationships. Pain plus distress, pain plus sleep, pain plus a decrease in valued activity. It can cause significant emotional distress and changes in our behaviour. We may use healthcare more, or our work may be affected, or our activity. Not everyone with a chronic pain condition is deconditioned. Some people are extremely fit, but struggling to cope with specific activities. There is some evidence to suggest that severe chronic pain or widespread pain is associated with an increased risk of mortality, independent of socio-demographic factors. A systematic review carried out by Smith and Macbeth in 2014 looked at the relationship between chronic pain and mortality. Such a link stresses the importance of treatments aimed at changing behaviours. Chronic pain is recognised as a condition, a diagnosis in its own right, according to the International Classification of Disease. It is associated with poor quality of life, often as bad as Parkinson's. We have entitled this talk, Conversations and Interactions. This photo is a glass sculpture by the American sculpture artist Dale Chihuly in a recent exhibition at Kew Gardens. It speaks to me of entanglement. I have used it here to demonstrate how complex humans are and how complex our interactions can be. We want to reflect on our everyday clinical conversations and encounters in a different light, spotting techniques that can be used in everyday clinical practice. What makes someone come to see you as opposed to your competitor if you're in private practice? What happens if we lose someone in the clinical encounter? What does this mean? A loss to business, behaviour, reputation, repeat business, etc. Our patients come from a complex, entangled background, as do we, with beliefs, experiences, memories, emotions, as well as a multitude of sensations. We are trying to find a way in through conversing, through conversation. It's hard, and we have all experienced difficult encounters and felt unskilled, thinking we must or we should have skills in this. We think we should know how to communicate, but we can all learn ways to improve and manage better in the moment. Pain management aims to promote sustainable behaviour change and encourage individuals to do more of what matters to them rather than directly reducing pain. Changing behaviour is challenging. It takes courage, awareness of what we, both clinicians and patients, are doing, our habits and behaviours, what is helping and what is not, and a willingness to lean into things that are difficult or different. As a demonstration, a quick experiential exercise that I'll invite you to take part in, one that I use very regularly with clients. Can I ask you or invite you to cross or fold your arms? Notice how that feels. Now, can I ask you to cross your arms the other way so that the other hand is on top? How does that feel? Perhaps a little bit strange, weird, it doesn't quite work, or maybe it's fine for you. Doing things differently feels strange, often uncomfortable. A lot of the work we do is about exploring changing habits and behaviours with our patients and seeing where there is wiggle room to make changes with the pain. A large body of research shows that methods within broadly cognitive behavioural approaches are the most direct methods for targeting behaviour problems relating to chronic pain. A question for you. What does psychologically informed practice mean to you? Can we maybe spend a moment thinking, or perhaps jotting down some ideas? We have asked this a few times. These are some of the ideas that come up in discussion: listening, communication, pain, language, awareness. It can be confusing and overwhelming. It may also feel very familiar and normal to you. We hope to shed a little bit of light on this. At this point, let's take a moment now to bring to mind someone you have struggled with, someone you have had a difficult conversation with. Perhaps they have been angry, disruptive, a person who says just yes to everything. Maybe they were ambivalent, or distressed, or confused. Take a moment to look at this next slide. What does this picture evoke for you? It is perhaps the last 5 minutes of your session. Your client is distressed. What is your response? What do you feel in your body? What thoughts, what emotions come up for you? What do you tend to do in these situations? There is no right or wrong here. This is just an opportunity and a chance to reflect. This next slide shows the diagram of the mature organism model by Louis Gifford. You are probably familiar with this. It represents the fundamental pathways into and out of the brain and central nervous system that are required for survival. The sensation of acute pain is a conscious signal of a physical threat that, in parallel with an emotional response such as fear and/or anger, motivates and brings about a change in behaviour to further our chances of recovery and survival. Further on, pain helps us to become physically vigilant and to often avoid use of an injured part. As the pain persists, it can become less helpful, and we are often still responding to perceived threat to our tissues, in our environment, and as a result of this, our behaviour alters and changes. Pain is itself an output. The brain scrutinises the environment and responds. How we think about a situation, or the pain that we experience, is linked with our emotions: embarrassment, sadness, anxiety. The unpleasant sensations, our past experience, our memories, all feed into our behaviours consciously and unconsciously. We may avoid, we may push through. For example, if the last time I tried to go up the stairs, my pain went through the roof, I am cautious to try this again. Maybe I compensate with my movements. I can get up out of a chair just using my right leg very effectively and avoiding the left, which may result in time in weakness and disuse. A very common behaviour we see in clinic is holding the breath, tensing and bracing. We all do it, often in an attempt to avoid and control the pain, often without any awareness of this. Oh yes, I'm holding my breath again. I want to talk about avoidance. Avoidance is a normal, understandable human response to difficult sensations, emotions, and experiences. We and our clients typically avoid physical sensations and emotions and situations that are difficult. It is more than just pain that can stop us. It can be fear, but also embarrassment, shame, confusion, sadness, guilt, excess sweating, etc. Often our behaviours have immediate consequences. If we get an increase in pain, I reach for my pills. In the short term, this can be helpful. But what are the consequences in the longer term? We can get relief from anxiety by avoiding. We can get a reduction in symptoms. We may feel safer in the short term. However, persistent avoidance may be costly, harmful, and inefficient, and the inability to tolerate distress may lead to other behaviours, escape behaviours such as alcoholism. Avoidance can interfere with our ability to do the things that matter: relationships, pursue friendships, take on responsibility at work, travel, if we have the opportunity to do that. As a physiotherapist, we have a very useful road into behaviour change through movement, through doing. It's very easy to say, yes, I understand, I get it, that I'm avoiding. But then when you explore doing an activity such as bending, running, getting on a bike, your client says absolutely no way. Let's think about our own behaviours with movement. This slide shows a couple of options for you. I'm going to invite you to stand up and explore an activity with me, such as rolling your neck all the way around in a big circle. Now, obviously, it's up to you how much or how little of this you do, and you make the decision about that. As you do this movement, what sensations do you experience? Possibly there's some grinding, some stiffness. Perhaps you've been working at home for a long time and your body has got quite tight. What emotions come up for you? Anxiety? What thoughts? I don't like this. I should be careful. What about last time? I shouldn't do that. I was taught at physio college not to do that. This will hurt me later. How do you approach movement? Do you do it cautiously? I just push through. Let's pick another movement. Perhaps explore the movement of bending forwards, towards your toes, or towards your knees, again, whichever part or element of that movement feels available to you. What do you experience? Sensations, emotions, thoughts. What do you do? It can be very useful to write all this down with your patient as a way to explore that maybe there is more than just pain. Maybe there are the other barriers that get in the way. A couple of questions to consider in your clinical interactions. Is there a problem with avoidance? How does avoiding help us in the short term and in the longer term? How do we track avoidance in our patients? What is the function of a patient's behaviour? Why is the patient behaving in this way? Is there something in their past history, experience, previous treatment, fear, anxiety? What might be feeding into the avoidance? Avoidance of what? Possibly increased fear, emotion, pain. Let's think about some common safety behaviours in the absence of neurological deficit. I call these blind spots. Behaviours that keep fear at bay, to decrease feelings of threat. If I do this, it'll keep me safe. Carrying a stick or a crutch, knowing every toilet en route, keeping our back straight when bending, carrying medications with you. If the behaviour is happening in appointments and sessions, then it's very likely happening elsewhere in their lives. You may have been the first person who has brought it to that patient's attention. We all get very good at finding ways to do things. I get out of a chair one way. I always hold my breath when I'm doing a challenging movement or activity. The power therapeutically can be in helping our patients to spot some of these behaviours that might well be safety behaviours. It may be helpful for them to notice and for you to name with them the behaviours. The patient is then in a position that they can choose how they might do or approach things differently. If therapy doesn't address these behaviours, such as fear, embarrassment, these may well last and serve to maintain the behaviour, possibly fear avoidance. For example, being afraid of being bumped into. They might therefore avoid situations that involve crowds, when social distancing is not an issue. By addressing safety-seeking behaviours, it can demote the influence of feared emotions and sensations. The aim here is not to reduce distress, fear or embarrassment, for example, but to enable a change in behaviour. Behavioural experiments, trying out and exploring behaviours, is often done quite cautiously by both physios and also psychologists. Sometimes we might make attempts to minimise our clients' anxiety. We may choose tasks or easier exercises that are less likely to evoke anxiety or other emotions in both our patients and in ourselves. There is a very natural human urge to avoid and limit distress, and as a result we can at times miss opportunities for behaviour change. Michelle Krask has written comprehensively on learning theory. Rather than trying to decrease anxiety about activities, when we do exposure work, we are building on experience, challenging expectations, and creating new learning on top of old learning. The patient may say, "This wasn't as bad as I expected. I've noticed my safety behaviours. I was protecting. I was holding my breath." There is a lot of work done on exposure, Johan Vlayen, Michelle Krask, etc., and many references and resources that you can tap into. I often use the metaphor of skiing down a mountain to introduce the concept of psychological flexibility. This can also be walking a path or any habitual behaviour. We get very good at following the same path, and we can do it very, very well. If we can build awareness to what we are doing and an openness to lean into doing things differently, if we can widen out our repertoire of options, that can only be helpful. For example, can I have 3 ways to ski down rather than just one way? I might well be out of my comfort zone. It might feel odd, rather like the arm folding exercise. But rather than narrowing our options, we are exploring widening options of how to do. For example, I always walk the same way, perhaps struggling, looking down, using aids. Can it be helpful to explore how many other ways I might do this activity, perhaps fast or slow, cautiously? If I always approach activity at 100%, how does it feel to do perhaps just 10%? Let's take a moment to reflect again. Can I invite you to bring a difficult clinical encounter to mind? Notice the judgments that come up. I should have said this. I should have done this. What are your thoughts, feelings, sensations in your body as you remember this encounter? How did it make you feel? What emotions showed up? What did you do in that moment? We can use pauses in our interactions as a space to regroup and then to make a choice about how to proceed. We often rush through our day. It's important to take a moment to reflect. Let's touch on what we can do with our experience, our resources, in our daily clinical practice, whether that is virtual or face-to-face. There are a lot of different approaches, but we don't all have training in these, or indeed access to supervision. A few, for example, ACT, mindfulness, CBT, compassion-focused therapy, narrative therapy, behavioural experiments. Leila will come on to some of these a little bit later in the talk. We can use an element of an approach to enhance our practice or the interaction. Some of us may be less comfortable with this and use more of a therapeutic alliance style type in our interactions. Metaphor is used quite a lot in pain management sessions, often as a means to explore a concept in a helpful way. However, it is important to pick up on a client's cues and to not over-metaphor, and to notice and track how people are responding to the metaphor you have chosen. The finger trap is one we use often with clients to describe the struggle with pain. If you remember those finger traps where you put your first finger either end of the trap, the more you try and pull away, the more the trap tightens. As you gently lean in towards that, you're able to pull your fingers out. With pain, the more we struggle, the worse it gets. Another metaphor could be pushing a beach ball down into the sea. All your energy goes on trying to push this down and to control it, which can be both exhausting and at the same time it is taking up all of our focus and we are not able to see what else is around. We're fighting a constant battle. Let's talk about values and goals. As physiotherapists, we are very good at setting goals. What is the difference between a goal and an activity that is value-based? Let's think about values. Let's think about life domains, health, leisure, relationships, work. If we manage to do activities in all these domains, our mental well-being is better. There's a sense of balance. but often sometimes we are, for example, very focused on one area, such as work, and other areas of our life get dropped. I like to think of goals as things that we can tick off. We achieve them or not. Values are our life direction, our life compass. We are continually working towards them. What type of practitioner do I want to be? What type of parent, sister, friend do I want to be? If patients are setting goals that are not important to them, they are less likely to happen. Keep an eye out for goals that they are doing for someone else. Goals like, I want to be fitter, I want to be happy. Useful digging questions can be, if you were fitter, what would you be doing? What will being fitter look like? If they are repeatedly not achieving the goals, perhaps they are not important. Perhaps other things are getting in the way. This may help open a conversation, and that is an equally valuable use of your time. Remember that it is a process. It's maybe something that you say in that appointment or that interaction that creates an awareness necessary to make a change. The patient may keep coming back to it. It's important to be aware of how we ask questions, how we pick up on cues, with empathy and a non-judgmental stance. A little exercise that I'll invite you to have a go at. Again, this can be done very easily with a client. It's called the post-it note. If you have one of the yellow stickies or any colour sticky note, or a piece of paper, bring a goal to mind and think for a moment, why is this important to me? Is it for myself? Is it for others? What is the value? Why do I want to do this? It could be walk to the shops, get on a bicycle. Is it a valued goal? Ask yourself, out of 10, how important is this goal to me? Write this down on one side of your post-it note. Now spend a moment thinking about doing the activity that you've written down. Think about all the things that might get in the way. The thoughts, the emotions. I haven't got time. It's hard. It's painful. The sensations, the environment, the circumstances that might prevent you doing the goal that you've written down. Write all these on the other side of your post-it note. With anything important to us, it comes with barriers. What do? On one side we have the goal, it's important to us. On the other side, we have all the things that get in the way. What do we do with this? Do we rip it up and throw it away because the barriers are too strong? But at the same time, we also then lose the goal that is important to us. If it is important to us, can we make a first step? Can we put this piece of paper, this post-it note, in our pocket with all that comes with it and carry it with us? Can we make a commitment? Again, there are many different methods to tap into values work. The 80th birthday party, the bullseye, some of these are mentions in resources. Perhaps now is a good moment to take time and ask yourself, what is one thing that I can take into my clinical practice next week? Thank you.
My name's Leila Heelas and I'll be presenting this next section. When we are delivering psychologically informed physiotherapy approaches training, often physiotherapists tell us that they're worried about opening up a can of worms. And this was found in an action research study in my place of work. Physiotherapists also expressed concerns that when they were discussing sensitive subjects with patients, they were worried that they wouldn't have adequate skills to effectively manage the situation, and they were worried about causing harm. A metasynthesis of qualitative research, which was about physiotherapists' use of biopsychosocial approaches, found that physiotherapists often found they had greater satisfaction when using such approaches. It improved their understanding of psychosocial factors affecting clients, and it enabled communication which improved therapeutic alliance. However, in the same study, even experienced physiotherapists found that they had discomfort when learning these approaches, and they sometimes found it difficult and overwhelming. In a study of physiotherapists working with clients with low back pain, some physiotherapists tended to assign negative personal characteristics to individuals who were expressing psychosocial issues affecting their pain. And the authors concluded that this led to stigmatizing of these patients. Perhaps this is unsurprising when, at undergraduate level at least, we have very little training or knowledge of psychologically informed approaches. A study entitled Selling Chronic Pain looked at physiotherapists' lived experience of explaining non-specific low back pain. It looked at physiotherapists working NHS and private practice, and it highlighted the links between satisfaction and therapeutic relationships, as well as good communication being essential in collaborative working and shared decision making. Physiotherapists in this study reported that they valued emotional intelligence and adaptability and responding to patient cues, which they felt was crucial to building a therapeutic relationship. They thought that they could get patients on board by drip feeding information over time, and they termed this planting seeds and laying foundation. But at the same time, they felt a sense of pressure to convince patients to buy an understanding of a diagnosis, which at times was at variance with the client's beliefs. And this created a paradox of both attempting to be patient-centred, but also needing to sell their own perspectives. And the authors of the paper suggested that this was paternalistic, and that patients' views could be seen as barriers to overcome, rather than to collaborate with the patients. In motivational interviewing, this is called the writing reflex, where we want to set things right. So when we come across an individual who is displaying ambivalence, then we may try to counsel, persuade and teach, and this in turn may result in more forceful opposition. So the idea is that we try and inhibit this writing reflex when it arises. So what about experts by experience? So what is the experience of people living with persistent pain? A mega-ethnography was conducted, which is similar to a meta-analysis, but involving qualitative research. And this paper conducted an evidence synthesis of 187 studies and included 5,000 participants. 7 conceptual themes emerged, some of which were that life was impoverished and confined, that people felt they were struggling against their body, that they had lost personal credibility, and they expressed the need to be treated with dignity. I've just highlighted a few quotes from patients in this study. Unfortunately, some people did feel stigmatised because of their pain, and they expressed that they thought that health professionals felt they were difficult or demanding. Rather than looking for a fix or a cure, they really wanted clinicians to understand and listen to them and show an interest. And some of them were carrying a heavy emotional burden. There was a sense of shame, loss and distress. There are various ways in which clients can get stuck. Firstly, there's the concept of experiential avoidance. This is the avoidance of unwanted internal experiences, such as pain itself, or perhaps other emotions like fear. Some individuals tell us that they feel fearful about going to their corner shop in case they're unable to walk back home again. Hooking into unhelpful thoughts can occur, where we get caught up in beliefs. We've probably all experienced working with an individual who has beliefs about structural changes in their spine, and they have concerns over undertaking certain activities or exercises in case it causes them damage. But we as therapists can also hook into thoughts. Perhaps we could stop to notice them, particularly when we're struggling in a consultation. And hooking into thoughts can lead to unworkable action, where we may persist or struggle against pain. So, for example, a marathon runner with chronic knee pain may try and keep up with the same level of training and not be able to achieve this, leading to feelings of failure. Or there may be a lack of action altogether due to emotional and physical discomfort. And lastly, there can be a loss of valued directions, and we use the birdcage metaphor to describe this. Often individuals with persistent pain tell us that life feels like it has shrunk, social opportunities have diminished, and only the necessary tasks for the day might get done. Physical activities have slowed down and reduced, and so life begins to feel like a bird confined in a cage. So pain management strategies are used to widen the bars and broaden horizons again. There are some common responses of therapists to sticky situations within consultations. Sometimes qualitative research tells us that if physiotherapists see a patient as particularly complex, this may bring up feelings of discomfort or feeling under pressure, and then we may feel like we have to refer on more rapidly, either to someone inside the practice or to another service. Or we may feel we have inadequate resources, and that, or perhaps that it falls outside the scope of our practice. Also, when finding consultations challenging, physiotherapists may fall back on structural definitions of pain. We may try and use persuasion. Perhaps we feel that it's always important to explain why people have pain. But do we always need to challenge maladaptive beliefs when we come across them? Is it always helpful? Instead, we may wish to consider the impact of doing this on a client's behaviour. Does it get them where they would like to get to be? In the worst case scenario, it can be mistimed or inappropriate altogether. So if we notice that our tendency is always towards compulsive explanation, perhaps we can ask, would an explanation here be helpful? Other common responses include inflexible rules. Sometimes we fall into patterns of behaviour. At times we may feel obliged to provide a fix, but it's good to remind ourselves that often people with persistent pain are not asking for a fix, and there may be complex contextual factors that are contributing to a presentation, which has often started a long time before the consultation. Sometimes we may be following our own agenda, be that time, a particular treatment approach that we think is useful, or perhaps we're following something someone has advised us to do. However, when we do this, then we may miss cues and fail to track language, or not follow up on something somebody has said, or not use a person's own words. And we all do it. We may be tired or having a bad day, but if we can notice and acknowledge what is happening, then we have a chance to change it. We might even say, I'd like to take a moment to digest what you said before you embark on the next stage of the consultation. And in our desire to embrace psychosocial factors, Sometimes, unfortunately, we may dwell on the negative. John Lorna calls this psychologizing, where a person feels obliged to discuss their feelings, or they may feel that the negative has been magnified. And this in turn may make them feel quite low at the end of the consultation. Again, permission seeking here might be helpful, and just checking whether they feel that talking about these things is relevant to their current problem. When patients come to a physiotherapy consultation, they're not always expecting to engage in a psychologically informed approach, so it can be useful to gain consent. And these are some examples of phrases that you could use with individuals, and it's useful too to document this into notes. And it also helps to set the scene and set the agenda so that an individual knows what to expect from their consultation. There are a multitude of different approaches that physiotherapists can use in psychologically informed practice. Motivational interviewing, acceptance and commitment therapy, cognitive behavioural therapy, just to name a few. If we feel less comfortable with using psychologically informed techniques, then we may wish to adopt a more coaching or advice and reassurance type style to develop a therapeutic alliance. Or we might wish to use elements of an approach to enhance our practice. So, for example, if we're working with an individual that expresses fear about going out with friends in case they hold them back, we might use cognitive reframing, which is a cognitive behavioural therapy technique, to assist that individual with challenging their thoughts. We can also use narrative-based practice and normative practice together in the same consultation. John Lorna discusses this in a Physio Matters podcast. So, for example, if we're asking questions about cauda equina, depending on the individual's responses, we may need to be very directive. However, if we're having a more narrative-based conversation, they may disclose to us that they have some irritable bowel symptoms that get in the way of them going out socially, and this would enable a better understanding of the context and complexity of their individual situation. The beauty of narrative-based practice is it works on the assumption that the person is not the problem. It values the lived experience of the person and looks for their meaning rather than our interpretation. It also aims to develop hope and encourages connection with significant others. It recognises the skills and strength of the person and highlights their resourcefulness, which we can sometimes forget to do in a consultation. If we wish to develop more advanced psychologically informed practice, we recommend supervision. The Physiotherapy Pain Association is looking to develop online supervision once a month for its members. Many physiotherapists have received training in motivational interviewing, and again, this is an approach where we could use elements within our practice. If, for example, we come across an individual who's perhaps had multiple sessions of physiotherapy before and they've not found them helpful, or perhaps they've had conflicting diagnosis and they're feeling a sense of frustration, we can use motivational interviewing to assist. Firstly, we can express empathy, noting that they've already had a difficult time, and this helps to build a therapeutic alliance. Rather than trying to defend our position or explain or justify, it can be helpful to ask for permission, to check out that it's okay to continue with the consultation. And this helps to foster a sense of agency for the person that we're dealing with, which is what we're hoping to achieve in a self-management approach. If resistance is still evident, we might wish to suggest that we just do the assessment and then they can determine whether or not they'd like to work with us. In motivational interviewing, this is called rolling with the resistance. We don't need to tackle the resistance right there and then. We're likely to gain more engagement if we just allow it and note it. It's worth considering, though, that not everybody we work with will be lacking in motivation. Sometimes other barriers may get in the way, or there may be other emotional factors which are preventing people from developing some form of change. So it might not always be pertinent to use motivational interviewing. If you are interested in learning more about this approach, there's an excellent online course which is available on the Moving Medicine website for a fee. We'd like to introduce a case study to illustrate some clinical skills. The case study involves a woman that we shall call Emma. She fell downstairs 6 years ago and sustained an unstable wedge fracture which required surgery. This painting represents Emma. We hope that you won't find it offensive. We realise it's a powerful image. It's by the artist Frida Kahlo and it's a self-portrait. She herself was involved in a road traffic accident and had to undergo surgery for the spine, and the painting is called The Broken Column. The straps around her body represent the corset that she had to wear after surgery, and the nails represent both her physical pain, she also had polio, but also her emotional pain from the relationship with her husband. The sensuality of her body is also clearly displayed in this painting. She has tears rolling down her cheeks, but despite her pain, she was looking at the observer of the painting, and she is standing in the foreground of a beautiful but barren landscape. And in this way, this picture encapsulates the way that we like to work with clients in a pain management approach, helping people to live a full and meaningful life despite pain. So returning to Emma. Emma was 55. She had attended accident and emergency on multiple occasions since her spinal surgery. Once when she was pushing a cage at work and it had suddenly hit something and jolted. She tended to go to accident and emergency rather than visit her GP, and each time she was told that no surgical correction was needed. Eventually, after 6 years, she was referred to a pain management service. At her initial assessment, she was cheerful and making jokes, but was speaking quite rapidly and appeared nervous. She used visual language to describe her pain, describing her thoracic pain as like a vice deep inside her body. She wrung her hands together to describe this. She experienced spasms which resulted in freezing or falling down, and she found this extremely embarrassing. She was considering buying a mobility scooter and had stopped going out so much. She also felt overwhelmed by anxiety. She often found herself scanning the environment for hazards. And she'd been told in previous counselling to place her problems in boxes, but she informed us that the boxes were now overflowing and she wasn't sure what to do with her emotional responses. And in the gym, she tended to move with forceful movements, often clenching her jaw during activities that she tried. We decided to use the approach of identifying thoughts and emotions and how they relate to actions. This is an approach that recognises our hooks and helpers. At times we can become fused or melded to inner experiences and can only view the world through this lens. This is not necessarily problematic, but for example, if I started to think that I was a bad parent, then I may begin to feel sad, or I may begin to feel anxious that I'm not giving my children a very good upbringing, or disappointed with myself, or frustrated. And this in turn may lead to me spoiling my child, perhaps overcompensating for my guilt. I may begin snapping at them because I'm frustrated, or I may withdraw because I feel sad and depressed. And in turn, this may perpetuate the thought and the emotions and may prevent a broader perspective developing. Often these responses are in an attempt to gain control, but they may serve to take us away from who or what is important to us. But we can use categorization or sorting of these inner thoughts and emotions, and in turn our outer experiences, as a tool to notice and distance ourselves from inner experience, and to determine what actions might take us nearer to what or who is important. So with Emma, we first looked at her hooks. We spent some time working through the hooks that were catching her and taking her away from what was important. Hooks of themselves are not a problem, and we're not trying to make individuals feel bad or make them try and make their thoughts disappear. These thoughts will present themselves. The important thing is choosing what to do when they arise. Also, we need to take care that we validate any experience. Looking at hooks might bring up painful and difficult emotions. However, this may be the first time that an individual has had the opportunity to express their thoughts and feelings and assert their needs. Next, we looked at Emma's helpers. Looking at helpers assists with moving away from being stuck. It also enables individuals to identify that they can move towards what is important in the presence of hooks. And it's important to emphasize that there are no right or wrong behaviours, just moves that could be away or towards values. And naming what is happening is a cognitive process that helps individuals categorise and take steps towards behavioural change. And in this way, Emma tended to engage less in self-defeating behaviours, such as cleaning until she was in tears, and engage in more self-care or compassionate type behaviours, such as spending time with her grandchildren or chatting to her partner. And with time, and with use of other pain management strategies, she was able to go out and meet her friends again.
This rounds up our presentation. On behalf of Leila and Claire, thank you for listening. We hope you found this talk on conversations and interactions in pain management of good value and can explore some of these skills in your practice. For further reference, you can click onto the final slides, and please feel free to contact us for any questions.